Now we will discuss a short agonist flare protocol. The flare of the agonist action lasts for 3 to 6 days of initial down regulation. It increases the natural FSH and LH secretion, which is different than artificial gonadotropin from pituitary, which helps in better recruitment of the follicle. The FSH flare help increasing the LH receptor on the granulosa cells, leading to better LH action and better luteal function. So this is another advantage. The flare-up action helps recovery from the oral contraceptive pills induced down regulation of the ovary, which causes very low LH level if it, and this disadvantage is not there when the short agonist protocol is used after OC pills. When we are using short agonist protocol, the early follicular progesterone elevation sometimes occurs, but it is not so detrimental. The treatment of the short agonist protocol is less expensive. It is the protocol of choice for the poor responder, as effective as antagonist protocol in poor responder. But there are certain drawbacks of short protocol, like because of the agonist flare initially in the early part of the follicular stimulation, there are raised androgens, LH, progesterone, and it can worsen the results by affecting the egg quality and implantation. Of course, this is diluted by OCP pretreatment. That is the reason whenever you are planning to use flare protocol, OCP pretreatment is must. Elevated testosterone, it reduces the estrogen receptors in the uterine lining. So by that it disturbs implantation also. In elderly women, the ovarian stroma undergoes thickening and it becomes more sensitive to LH. So these are the advantages of increased androgen induced by flare. Sometimes in agonist flare protocol, the corpus luteal cyst is rescued and leading to a cyst formation. It has been observed that in flare protocol, the cancellation of the cycle rate are more in some of the studies. The results says that it is inferior to a long protocol, especially in normal responder. Now there are various adjuvants which are used with the protocol. The oral contraceptive pills is the most important adjuvant commonly used in all protocols sometime or other time. Whether you love, whether you hate, but you cannot neglect oral contraceptive pills. Now what does it do? The oral contraceptive pill reduces the LH, which leads to a decreased androgen production by ovaries. The estrogen component of the oral contraceptive pills, it increases sex hormone binding globulin, leading to a reduced circulation of the free androgens. The progesterone component of the oral contraceptive pills, it compete with the 5-alpha reductase at androgen receptors. It decreases the ACTH, leading to reduced adrenal androgen production. So this was In brief, what is a mechanism of action of oral contraceptive pills? It helps in the scheduling of the cycle. That is the most important advantage of the oral contraceptive pills. It prevents the unrecognized pregnancy at the time of starting of the stimulation. Whenever you want to start oral contraceptive pills, it has to be started from day 2. The minimum 15 days for long agonist protocol and 7 to 10 days for agonist flare or antagonist protocol is must. Ideally, OCP pills should not be used more than 45 days, because if you use for such a longer period, it causes profuse down regulation and suppression of the ovary. So the basal LH level at the starting of the stimulation is so low that if it goes unrecognized and if you stimulate with the recombinant FSH, the chances of getting poor egg maturities are very high. Plus, it can affect the success of agonist trigger also. The prolonged OC pills, it leads to increased gonadotropin consumption. Whenever we are giving oral contraceptive pills, please remember down regulation starts after 5 days of last oral contraceptive pills. After oral contraceptive pills, whenever you want to stimulate the ovary with the gonadotropin, the washout period is 5 days, which is must. The overlapping of the oral contraceptive pills and agonist should be commonly 5 days, but it is as little as 1 day also works. But in the most of the center, 5 days overlapping is practiced. To overcome the marked suppression of LH resulting from oral contraceptive pills, the supplementing LH is helpful. It can be done by substituting some pure FSH with HMG, but the LH activity in HMG is variable. So, usage of small dose of recombinant LH or as a modification, small dose of SCG like 20 to 30 units in agonist cycle, 10 to 20 units in antagonist cycle, or 5 units in hypo cycles daily should be supplemented. Another good adjuvant nowadays commonly preferred in antagonist cycle is estrogen. It is also useful in poor responder for scheduling. The estradiol 4 mg started from the mid-luteal phase and it can be continued up to 14 days max, irrespective of onset of the menstruation. But it should be remembered that gonadotropin stimulation to be started after stopping the estradiol 1 day without estradiol. So washout period is only 1 day. The estradiol 4 mg daily for first 2 to 3 days after getting the menses also used, and which helps to prevent advanced follicular maturation and short follicular phase. It helps in synchronization with the endometrium, but the gonadotropin consumption is increased if you use estradiol like this. The estradiol helps in scheduling the antagonist protocol, and it helps in synchronous follicular growth. The asynchronicity of the follicular growth, which is commonly observed in antagonist protocol. So, if these cycles are pre-treated by estrogen to certain extent, to larger extent, the asynchronicity of the follicular growth can be avoided. After stopping estrogen, there is a rebound rise of endogenous FSH which can act together with exogenous, so it works in a better way. The response is increased especially in poor responder. So this was regarding the role of estrogen in IVF stimulation. Now once you have started IVF stimulation, what are the important points, practical points, which can help you in monitoring of the stimulation? Certain facts you must remember, should never forget, that estradiol level doubles in 2 days. The plateau more than 3 days are associated with poor outcome. The mature follicle contributes 200 picogram each. The lead follicle normally grows 2 millimeter per day. The follicle size of 8 to 10 millimeters, they acquire LH receptor, after which for the further growth FSH is not mandatory for this follicle, and this follicle can be grown further by just stimulating, just giving LH or SCG in a lower dose. The estradiol continue increasing for 1 day after stopping gonadotropin, whereas the follicle continue growing for 4 days after stopping gonadotropin. So when you want to judge the effect of gonadotropin on follicular growth, you must wait for 4 days after starting the gonadotropin and continuing the gonadotropin in the same dose. The change of the dose, if required, it can be done after 4 days only. Now, if the serum FSH level is more than 20 international unit on cycle day 7 or stimulation day 5, it may indicate that FSH receptor saturation has occurred in granulosa cells, and that is the reason why the serum FSH level is high. And therefore, the addition of more exogenous FSH would not result in increased follicular response. So this is a very important practical point. During the stimulation, after initial 4 or 5 days of the stimulation, you are given adequate dose of gonadotropin, and you feel that the follicles are not growing. Now if you are in confusion and you want to judge whether you should increase the dose of gonadotropin or you should not. So if you measure the serum FSH level, if it is more than 20, you should not increase the dose of the gonadotropin because it is not going to help. All the receptors are occupied. The follicular growth was considered to be asynchronous when 1 or 2 leading follicles were more than 4 millimeter larger than the rest of cohort. So this is called asymmetrical follicular growth. Now we will discuss the microflare protocol. and role of androgen. The transdermal testosterone, which increases the intrafollicular androgen level, and it may upregulate FSH receptors on granulosa cells. It enhances the response to gonadotropin and augment follicular growth. To improve the clinical pregnancy and live birth rate in poor responder, it is used. The lower doses of gonadotropin and significantly fewer days of stimulation were also observed when transdermal testosterone was observed. The exposure of cohort of follicles with a differential sensitivity to extremely high serum concentration of the FSH may result in rapid development of one or two follicles who were having lower threshold and those who were more sensitive, while not allowing enough time for the remaining follicle to develop and mature, causes asymmetrical follicular growth. The dose of the transdermal testosterone 25 mg daily, so which is 2.5 gram 1% of androgel, was administered from the day of FSH stimulus injection and were interrupted until the day of ovulation trigger. So at any time when you find that stimulation day 7, cycle day 7 after stimulation day 5, when the FSH exceeds the 20 international unit, and if you find that the follicular growth was slow or asynchronous, the gonadotropin should be discontinued for 4 to 7 days. The poor responders are resistant to gonadotropin stimulation and have inadequate follicular growth. Some of these patients have a very low number of small antral follicles at the beginning of the cycle, whereas others may have more antral follicle during the early follicular phase, but they fail to respond to a gonadotropin stimulation. So when you stop the gonadotropin during costing, E2 level usually continues to rise for 1 or 2 days after withdrawal of the gonadotropin, as we described couple of minutes back, before declining abruptly. The follicles more than 1.5 cm normally continues to grow and may survive for several days in the absence of gonadotropin support. Granulosa cells within the smaller follicle, however, undergo apoptosis, resulting in follicular atresia. But in agonist cycle, when we stop the gonadotropin, the outcome, however, was clearly different when testosterone gel were applied, because they observed that E2 level continued to rise, the follicles kept growing even after 1 week of gonadotropin cessation, and large proportion of follicle less than 1 centimeter continued to grow steadily while maintaining the significantly lower serum FSH level compared with the pre-interruption period and control group. This highlights the difference in the effect of gonadotropin withdrawal between women with poor response compared with those with the hyper response. In flare cycle, this was observed. So the logical explanation behind this Why after costing the estrogen kept increasing? Why follicle kept growing? So the logical explanation in flare cycle due to milder suppression of pituitary interrupting gonadotropin may have resulted in some residual endogenous gonadotropin that facilitated the growth of small antral follicle. The another factor involves is a possible direct stimulatory effect of GnRH agonist on the ovaries. The E2 levels declines more abruptly during costing when both agonist and gonadotropins are concomitantly withdrawn. Then, when the GnRH agonist is maintained and only FSH is withdrawn. So, what they observed, when the gonadotropin agonist both were interrupted, the E2 level declined more abruptly, whereas if the gonadotropin only was interrupted and agonist was continued, the E2 kept increasing. Means there has to be some direct effect of agonist on the follicle. In addition, the fall in E2 is quicker and the duration of the costing generally shorter for antagonist cycle compared to the GnRH agonist based cycle. It is possible that GnRH agonist may bind to ovarian GnRH receptors to stimulate the follicular growth directly. So the androgen have been shown to upregulate the FSH receptor expression. Therefore, the androgen induction of FSH receptor along with the declining serum FSH level resulting from withdrawal of the FSH may add together to sensitize growing follicle to gonadotropin and increase the gonadotropin utilization efficiency. The androgen also provided the substrate for FSH induced aromatization, possibly contributing to increased E2 level during the gonadotropin interruption. These patients seem to have had improved overall response during the current cycle, all of which progressed to a oocyte retrieval. E2 level and the number of the follicle more than 1 centimeter almost tripled during the short interval of gonadotropin interruption and were significantly higher compared with the control group. So this is suggestive of improved gonadotropin utilization after intervention. To some extent, the total number of the oocytes retrieved correlated with the basal antral follicle count. The number of the dominant follicle at the time of ovulation trigger also correlated with the number of the mature oocytes retrieved, suggesting the optimal stimulation of the antral follicles present. So, this study was basically conducted in the agonist flare cycle when they observed that the growth was not good or there was asymmetrical follicular growth. They continued agonist but they stopped gonadotropin and patients were advised to apply a testosterone gel. So testosterone gel changed the follicular environment for efficient utilization of the gonadotropin, and those follicles who were lagging behind, they made up and they enter into a growing follicle without much of the asymmetry. This was in nutshell the crux of the whole conclusion. Now what is a costing? Costing is a temporary stopping gonadotropin stimulation. The costing more than 3 or maximum 4 days is not advisable. It is not at all advisable for antagonist protocol because in antagonist it creates lot of endometrial embryo asynchrony if the costing is done. The early costing is done to prevent OHS. So, what are those criteria when you should do costing in long agonist protocol to prevent OHS? Those who are practicing long protocol, they should be always cautious for the prevention of OHS. So, whenever they observe lead follicle reaches 15 millimeter and more than 10 mid-size follicle per ovary on either side, that means 20 mid-size follicle. The E2 is more than 1500 picogram. The costing for 3 days is advisable. When the E2 is still after costing more than 3000, or if the trigger is anticipated beyond day 4 of the costing, cycle cancellation will be a better choice. The pregnancy rate falls if at the end of the costing E2 falls by 60%. So this is also an important thing. Now, how to prevent OHS? This we will discuss in next audio clip. Thank you very much.